Good evening and welcome to Northwell's Rehabilitation Lecture Series. This is Tom Phillips, Senior Director for Northwell's Physical Medicine and Rehabilitation Service Line. Let's quickly go over some of the session-specific information. In order to be eligible to receive CEUs, you must be logged into this session with your full name and credentials. You must be registered for this event through Eventbrite, and you must attend the session in its entirety. Please make sure that your microphones are muted and your cameras are turned off. Please use the chat feature in Zoom to ask any questions you may have, and our faculty will answer them via chat. If you have questions after the webinar, please email them to us at rehabeducation@northwell.edu. Please note that you will receive your certificate of completion within the next 10 business days. As always, please share your feedback with us through the survey that will be emailed to you all. Session 1 of this two-session series will discuss speech-language pathology management of patients with lung cancer. Let me introduce you all to this evening's presenters. Dr. Nagasri Sitaramu is an associate professor of medicine at Donald and Barbara Zucker School of Medicine and the assistant director of medical oncology division at Northwell. Dr. Patrick Martone is a board-certified physician in physical medicine and rehabilitation and is an assistant professor at Donald and Barbara Zucker School of Medicine. Annie McGarry is the manager of speech-language pathology department at Northwell Health's Peconic Bay Medical Center.
Hello, everyone. Thank you so much for giving me an opportunity to speak at this webinar. Over the next few slides, I'll be walking you through a rapidly evolving landscape of lung cancer. For those who don't know me, I'm an associate professor in the Department of Medicine, Hem-Onc, and let's get started. These are my disclosures. So this is not something that you're not familiar with, but I just wanted to point out how signs and symptoms of lung cancer can be extremely variable. It could be related to mass effect within the lung itself. It could be related to pressure on the surrounding structures, such as the esophagus. It could be a result of a metastases, such as bone pains and CNS symptoms related to brain mets. But we're hoping that over the next few years, or in the future rather, we will be able to detect patients before they're symptomatic through low-dose screening CT for eligible patients and through prevention. Just keeping into the theme of the webinar here, I just wanted to focus on dysphagia and dysphonia in patients with lung cancer. So this could be a result of pressure directly from cervical adenopathy or mediastinal adenopathy, or vocal cord paralysis from recurrent laryngeal nerve involvement. It could be due to mucositis due to treatment, or it could be related to overlapping infections such as Candida and CMV. Of course, there's field cancerization effect, and there could be second primaries that we may need to look for in patients with debilitating symptoms related to swallowing and speech in the head and neck aerodigestive tract. They could be related to CNS and leptomeningeal involvement, or paraneoplastic syndrome such as Eden-Lambert, which we see with small cell, or myasthenia, which we see with thymic tumors, which cause severe decline in swallowing function, swallowing and speech. Or it could be just from asthenia, just overall deconditioning of patients with lung cancer due to their disease itself or their treatment. Lung cancer incidence and prognosis. We always want to see patients diagnosed at earlier stages, but that's not the case. And even today, a majority of the patients are diagnosed with advanced stages. But the prognosis, of course, is superior in patients with early stage cancers, and pretty dismal even today in patients with advanced stages, even though it is rapidly improving. This is a traditional view of lung cancer. We want our pathologists to tell us if it's squamous cell adenocarcinoma, large cell, small cell. We still depend on this, but our treatments have evolved just beyond this. We want more and more information from our pathologists, and I'll walk you through that in the next few slides. Treatment modalities, just an overview. Surgery for localized disease, and then we talk about open surgery versus minimally invasive surgeries, robotic surgeries, which are being done more and more with lesser morbidity to patients. There's always a debate about lobectomy versus sublobar resection, but still lobectomy or anatomic resections are still the standard of care. And then pneumonectomy in some patients who have central tumors or involving multiple lobes. Radiation for patients, this could be conventional radiation, or it could be intensity modulated radiation, or it could be stereotactic body radiation for very localized tumors, or in the context of oligometastatic disease, or very rarely proton treatment. And of course, systemic treatment broadly can be classified as chemotherapy, targeted treatment, or immunotherapy. Let's just focus for a second on early stage node negative non-small cell lung cancer. So surgical treatment is the preferred local treatment. Anatomic resection with lobectomy or segmentectomy is preferred over wedge resection. And of course, there should be adequate sampling of at-risk ipsilateral, hilar, and mediastinal lymph nodes. SBRT is reserved for patients who are medically inoperable or who do not want surgery. So SBRT or hypofractionated radiation for ultracentral tumors can be considered for some patient populations. But having said that, even within all these spaces, there is increasing research into integrating systemic treatment, particularly immunotherapy or targeted treatments with these special populations. There are other options such as radiofrequency ablation, cryotherapy, or sometimes even observations that we might recommend for some patient populations. Assessment of resectability. This is again something that you are all, you have more expertise in this, but I just wanted to devote one slide for this. A quarter of our patients, early stage cancer patients, are poor lobectomy candidates because of comorbidities. Thoracic surgical risk assessment is also evolving because of advancements in techniques in perioperative care. There are multiple guidelines for assessing who are candidates for surgical resection. But historically, we've been using cardiopulmonary function and pulmonary function tests as the primary focus, and it still remains that way. But then we also know that exercise testing is an important adjunct. I do remember my times at NYU when I was attending thoracic oncology, attending at Bellevue, where the surgeon would have the patient do the 6-minute walk and climb the stairs up and down to assess if they're candidates. So I think as an adjunct or in places where you cannot do a very thorough, like a more sophisticated cardiopulmonary testing, these simple bedside tests can be a great adjunct. Age per se is not is involved in risk assessment. But of course, with the aging comes a lot of comorbidities, and the elderly patients often are deemed, not the ideal candidate. And when the nodes are positive, this is node positive patients, hilar lymph node positive patients, surgical resection with lymph node dissection is the preferred local treatment. All these patients, there's an indication for adjuvant chemotherapy. But then now we are having increasing role of new adjuvant treatment. There are a lot of clinical trials ongoing, including within our institution, to look at new adjuvant protocols, particularly integrating immunotherapy and targeted therapies into the systemic treatment option for these patients before surgery. So it is, and again, becomes extremely important to make sure that these treatments do not knock our patients, into a position where they're unable to undergo surgery. So collaborating with rehab medicine is extremely important to make sure that these patients remain operable at the end of their systemic treatment. For patients who are not surgical candidates, chemo radiation is standard of care, followed by a year of immunotherapy. So for N2 disease, it's still a controversial area. And historically, the overall survival is like 20% for 3A and as low as 10% for 3B. So because there's a high risk for distant metastases, there's always a debate of whether surgery is the best option for these patients. The only patients today who undergo surgery with endo disease are those that we did not know had endo disease, and they were incidentally found to have endo disease at the time of surgery. For all other patients, it's a combination of chemotherapy and radiation, or neoadjuvant chemotherapy if the surgeon feels like they are surgical candidates. So surgical candidacy is extremely important at diagnosis, and most of these tumors are presented on a multidisciplinary tumor board. Multidisciplinary involvement of surgical, medical oncology, radiation oncology, and multiple other disciplines is extremely important to make sure that the patients are adequately staged and triaged for treatment. I'm not a radiation oncologist, but I thought these pictures are telling, and I just wanted to kind of bring up this, given the focus of this webinar. For locally advanced non-small cell lung cancer patients, conventional fractionation radiation using 3D radiation or IMRT are standard of care. So for this is for patients who have, there are large target volumes that needs to encompass not only the primary tumor, but also the involved lymph nodes. So the target often is in close proximity to normal structures. So the toxicity depends on, using the dose fraction ratio is extremely important, and also the ability to repair the normal tissue post damage. So the typical fraction is 1.8 to 2 gray per fraction in 30 to 35 fractions to a total dose of 60 to 70 gray. Is typically given for patients with limited stage small cell lung cancer. However, using IMRT to shape the dose away from normal organs is used more and more for non-small cell lung cancer, and that seems to have a more conformal dose planning than the conventional radiation. So on the left side, you can see how the 3D radiation can involve, can affect normal lung structures as well as the esophagus. Whereas on the right-hand side, you see how the dose is peeling away from the normal lung, but still the esophagus is still in the treatment line. So the toxicity depends on, the structures that are involved, obviously. So there's acute toxicity, and then there is, late toxicity. Acute toxicity is acute esophagitis for the most part. So this usually starts within 3 to 4 weeks into treatment. And it's complicated usually by thrush and acid reflux. And, we treat patients medically, but it's also important to make sure that they see our speech pathologist to make sure that their swallow is okay, they're not aspirating, and that they're able to take the foods that they're able to handle. Fatigue is a major side effect, and this, along with the esophagitis, can lead to significant weight loss. Dry, non-productive cough, just from irritation of the bronchus, or even sometimes pneumonitis. Dermatitis is something also that's pretty troubling for these patients and debilitating. Another group of patients here, patients with PD-L1 positive tumors who do not have any genomic alterations that are targetable. Stage 2 to 3A, recent studies have shown that there's improvement in disease-free survival when immunotherapy follows chemotherapy for up to a year. The drug here is atezolizumab, and at every endpoint, the curves stay apart. So this is standard of care now, again. So patients undergo surgery. At the time of surgery, we do genomic profiling, PD-L1 status, and then depending on what we find, patients are either receive the osimertinib if they're EGFR mutation positive, or enrolled in a clinical trial or receive immunotherapy. So these are extended treatments. We are moving into the neoadjuvant space for lung cancer here, integrating chemoimmunotherapy before surgery. So again, just I want to highlight how important it is to make sure that patients do not get decompensated during these treatments. And while they have the ability to improve cure rates, it's also important to make sure that they're able to proceed with surgery like was originally planned. So advanced lung cancer, it's a truly heterogeneous disease. Many people consider this as a chronic condition. So people are living longer with it. So that's an extremely important point to make here. So people are living longer, but they're living with the disease and the side effects of treatment. We're always looking for cure and sight, but at this time, we do have disease control for the most part, and patients remain on lifelong treatments. There's a section on oligometastatic disease. This is a completely different, seems to be a different cohort of patients where they have metastases to just a few organs, and they seem to do quite well. So it's a heterogeneous disease in multiple regards. Um, And we know that targeted treatments are extremely important. So genetic profiling of the tumors has become standard practice. It all started with a study called IPAS, which was a large study that showed that patients with EGFR mutation benefited from a drug called gefitinib. Um, and did much better with that drug than with chemotherapy. Now, osimertinib, which is shown on the slide here, has a significant improvement over standard um, first generation tyrosine kinase inhibitor. So pill versus pill, the superior drug is osimertinib. This is what we use as standard of care today. So with this, as you can see in the curves here, there are patients well into their third year, fourth year, doing very well on these treatments. So we have patients who are long-term survivors, but on active treatment. Now, the genomic profiling is so different today. As you can see, different genomic subsets of patients. So the classic definition or the classic categories of lung cancer, where you first saw in my first few slides, small cell, non-small cell, adenocarcinoma, squamous, is just not sufficient for us. It's really a genomic category of multiple different subsets of patients with targets that dictate the treatment. And these are the drugs that are either being approved for lung cancer or are in development for different subsets of lung cancer. And as you can see, I mean, this is not even an updated slide, but you can see the number of drugs that could be potentially used. And it's so important to understand the target that's being that the drugs are going after, or the particular drug itself, because the on-target side effects can be pretty intense and debilitating for a patient. Just an overview of the toxicities. It's so important to understand these individual drugs and how they affect, what are they targeting, what are the on-target side effects, and what are the off-target side effects that are so unique to each of these drugs. Of course, there are some drugs here that are mentioned that are not used in lung cancer, but I just wanted to use this picture as an example as to how unique each drug is in their toxicity profile. Moving on to the immunotherapy. So it's a new class of drugs that we're all aware now. It's a part of our most of our patients' journeys today during their treatment. And from neoadjuvant space to metastatic space, we use immunotherapy pretty much very frequently in our practice. So how does this work? So the engagement between PD-1 and PD-L1 is extremely important for cancer progression and survival. So interruption of this engagement through either inhibitors of 2PD-1 or PD-L1 can interrupt this engagement and lead to cancer death through activation of immune system. But these are not benign drugs. We all know that. This slide is busy, and it's meant to be busy just to highlight the importance that any organ can be affected with these drugs. So these are patients' own immune system that are charged up, so they're pretty much really free to go and affect or negatively impact any organ. So it's extremely important that we have partnerships within multiple subspecialties to make sure the patients are treated appropriately for their and timely for their immune-related side effects. I like this picture a lot. This is a conceptual framework for supportive care, palliative care, and hospice care. Supportive care starts at the time the patient goes through screening process when there is not even an evidence of cancer. Whereas palliative care is for patients who do not have a curative intent treatment for their cancer. However, even that definition is changing. So there is a lot of overlap between these areas, and hospice care is for patients who are undergoing end-of-life treatment. The supportive care is where there's a lot of room for collaboration and integration of multiple services to ensure that the journey is as seamless as possible. There is survivorship care that needs a lot of focus. In addition to monitoring closely for recurrence, it's important to make sure that the side effects from treatment are being addressed in a timely fashion. Stage 4 patients with stage 4 lung cancer are candidates for cancer screening. Previously, we used to not really focus on that, but it's extremely important to do so and make sure that they get appropriate immunizations and focus on their overall health. Such as physical activity, pulmonary rehabilitation, diet, and nutrition.
Thank you, Dr. Sita Ramo. Let me now turn this over to Dr. Martone. Dr. Martone, take it away.
As Dr. Sitaramu gave an excellent overview of lung cancer types and treatments, now let's focus on how these treatments can impact rehabilitation. Let's start with chemotherapy. As rehabilitation professionals, one of the big things we definitely want to be screening for in our patients who are undergoing chemotherapy is neuropathy symptoms. So those patients who are having numbness, tingling, is there a pain component to their neuropathy that we need to treat? Is there a functional component? Are they dropping things? Are they having difficulty with their balance? Any patient who's undergone that chemotherapy, we want to be screening for these things. As you can see, when we talk about neuropathy symptoms, it's important to really differentiate whether patients are having sensory or motor symptoms. It's important to screen your patients and look for if they are having those feelings of numbness and tingling, if they're having any burning pain. Those are things that we want to treat. Are they having any weakness? Are they having any difficulty with using their hands? Those are motor type symptoms that, again, we want to be able to evaluate for. In physical therapy, we can be evaluating our lung cancer patients with functional assessment tools such as the 6-minute walk test. That's a very good test to test the aerobic capacity and endurance of a patient, and something that we use to monitor progress during rehabilitation. Other tests such as the timed up and go can be very helpful for our patients with neuropathy or impaired mobility in general to discern what their fall risk is. It's important in a lung cancer rehabilitation program that we do promote exercise and that aerobic activity. Exercise is not only good for that aerobic activity, though, it also can help with these neuropathy symptoms. It's also very important, especially in patients who are actively undergoing chemotherapy, to be very aware of what their blood cell count lines are. So for instance, to be aware if a patient is anemic or they're neutropenic. If they're anemic, we really do have to be monitoring for if they're having excessive symptoms of fatigue or lightheadedness? If they're neutropenic, are we using appropriate precautions to avoid infections? And then thrombocytopenia, what are their platelet counts? So none of this is absolute contraindications to performing rehabilitation or therapies, but certainly, if patients' cell count lines are noted to be lower, we do want to be having appropriate restrictions and precautions. Occupational therapy in particular can be very helpful, especially with symptoms related to hand dexterity, as well as numbness and tingling, and those positive symptoms of neuropathy. In addition to ADL training, we can do things that are called desensitization techniques. And what that is using modalities on the hands or the feet to help change the sensory input, and that can help with those positive symptoms, which can often be quite debilitating. Lastly, we can also use medications for chemotherapy-induced neuropathy symptoms. Typically, we use neuropathic pain agents. There are other modalities such as acupuncture, medical cannabis as well. A lot of these neuropathic pain agents are also very good for post-thoracotomy pain syndrome, which we will go to in the next section. Radiation therapy can certainly have an impact on rehabilitation. Many times, patients undergoing radiation therapy will have significant fatigue symptoms, or cancer related fatigue syndrome with rehabilitation can be very useful for. We also want to be screening for other things. Is it creating a chest wall pain or any fibrosis symptoms? Are they having any neurologic conditions such as a brachial plexopathy with worsening numbness or tingling or weakness? These are all things functionally we need to be screening for as rehabilitation professionals. And lastly, there are surgical treatments which can impact a patient from a rehabilitation perspective. Newer techniques using video assisted thoracoscopic surgery has advantages that patients typically do not have as much significant pain as there is in things like rib spreading, which can be done in more open procedures. However, patients certainly can have pain syndromes associated with these surgeries that we as rehabilitation professionals can intervene on. A big component of treating lung cancer patients in rehabilitation is really identifying what's called post-thoracotomy pain syndrome. And so this is a pain that persists along the surgical incision site and can be described as a burning, dysesthesia, aching pain, and can be quite prevalent in this patient population. We want to go about treating post-thoracotomy pain through multiple modalities. So using neuropathic pain agents has been shown to be very beneficial for these patients, especially those who do undergo those open procedures where there is rib spreading. They're going to have things like intercostal neuralgia. Neuropathic pain agents can be very effective for that. Using certain types of therapies, such as kinesiotaping, can actually be very helpful. Kinesiotaping has an advantage of actually supporting the chest wall site while allowing for mobility and movement. There's use of modalities such as transcutaneous electrical nerve stimulation. This has been shown to be beneficial for pain symptoms in this post-thoracotomy pain syndrome. Then there's also actually the hands-on manual therapy and physiotherapy component to treating post-thoracotomy pain syndrome. So actually using your hands to promote rib mobilization for ribs that are restricted or have any dysfunction in them. Doing facilitated positional releases to promote diaphragmatic breathing. All of these things can be very beneficial for treating post-thoracotomy pain. So in addition to treating pain syndromes associated with lung cancer, we also want to really focus on that aerobic capacity and functional mobility. We can do this in multiple times within the continuum of care. It can be done as a prehabilitation or performing this before they even undergo any treatments. It can certainly be done during treatment and then after. What we want to do is we really want to be improving that aerobic capacity through doing things like cardio exercises, using treadmills, bikes. We can monitor this with things like the 6-minute walk test to see how patients are progressing. We also want to focus on certain respiratory and abdominal exercises to improve that breathing ability. One simple thing you can do in a lung cancer rehabilitation program is to really teach and educate a patient how to use incentive spirometry. This can help to expand the lungs and increase that respiratory capacity. And then again, we really do want to focus on that endurance training. So, doing things that will make a patient more active, that will increase that respiratory drive, increase their functional capacity. And when we do this during our lung cancer rehabilitation, we're always monitoring patients for their rate of perceived exertion. So, we want to get to that level where we are pushing them, but it's not going too far. And certainly, patients who have more oxygen requirements need to be monitored more closely. So, a lung cancer rehabilitation program can be quite extensive and actually involves many members of the rehabilitation team. Um, Speech therapy is especially important because they are going to be screening these types of patients. And when that patient's in your office, you really can take the time or a moment to see what other symptoms they may be having, where other rehabilitation professionals can really be helpful. So, as you're sitting and speaking with them, do you notice that they're having any difficulties with using their hands? Are they complaining of any numbness or tingling, that they have neuropathy symptoms? That'd be a great time to refer to physiatry, who can then determine would this patient be more appropriate for medications, for occupational therapy. When you're talking to your patients and you notice that they're even out of breath just from sitting there, that's a good time to again refer to physical therapy and physiatry to determine, well, can we get this patient in an aerobic endurance and abdominal capacity training program? Lastly, if you notice that they're in pain from their surgical incision, again, a great time to refer to physiatry to determine whether physical therapy might be helpful to do rib mobilization for their post thoracotomy pain syndrome. Do they need pain medication agents? And really, in this way, a team can act in a really coordinated manner to improve all of these symptoms that patients may be experiencing after and during treatment.
Thank you, Dr. Martone. Let me now turn this over to Annie McGarry.
Hello, my name is Annie McGarry. I am a speech pathologist at Peconic Bay Medical Center, and I am here tonight to talk to you about evaluation and treatment elements of a patient with lung cancer. First, we're going to talk about the impact of lung cancer on swallowing. Then we'll discuss the elements of dysphagia evaluation and interventions for improving dysphagia. So let's start with the impact of lung cancer on swallowing. First, let's look at lung cancer statistics. As you can see, lung cancer is the leading cause of death, with over 200,000 Americans diagnosed with lung cancer this year. The number of worldwide cancer cases is set to increase by 75% in the next 2 decades, with lung cancer remaining a major cause of morbidity and mortality. Dysphagia occurs in only a small percentage of these patients with lung cancer, of about 4%, but the frequency of this cancer means that larger numbers are affected. As cancer diagnosis numbers increase, so do the numbers of those patients with dysphagia. What we know is that dysphagia is usually a late symptom in patients with lung cancer. We know that dysphagia can develop secondary to a primary malignancy, metastasis, or treatment regimen, including surgery, radiation, or chemotherapy. And we know that patients with disordered swallowing prior to treatment have the greatest risk of developing post-treatment dysphagia, regardless of the agents or treatments used. And this, along with weight loss, has been a significant impact on quality of life and overall survival for lung cancer patients. The most common cause of lung cancer-related dysphagia is mediastinal compression of the esophagus, either by compression due to lymphadenopathy or tumor invasion. As you can see here, the mass is compressing the esophagus, which could have significant impact on the swallow. Another related dysphagia is from lymphadenopathy. This is the inflammation and swelling of the lymph nodes can cause compression and result in dysphagia. We may also see a secondary achalasia here. Bolus propulsion may be affected, as well as esophageal dysmotility. Another lung cancer-related dysphagia is due to the compression of the lymph node deposits on the pharynx and the upper esophagus. This compression can lead to dysphagia. Next, we have radiation-induced esophageal toxicity and oropharyngeal and esophageal infections, including ulcerations and esophagitis. The patient will most likely complain of discomfort and pain with swallowing here. Another related cause of dysphagia is vocal fold injury. The recurrent laryngeal nerve can be damaged from surgical intervention or from the tumor presence itself. This damage can result in compromised airway protection and reduced laryngeal sensation, which can lead to penetration and or aspiration. This can also alter subglottic air pressure and result in increased pharyngeal residue and potentially reduced ability to clear aspirated material. The cough response may also be compromised and ineffective here. Chemotherapy and radiation therapy contribute to the risk of dysphagia, whether in isolation or in a concurrent treatment. Most dysphagia that occurs during treatment is attributed to the radiation therapy or the synergenic effects of radiation and chemotherapy. Chemotherapy doesn't generally cause lasting dysphagia, but can make the effects of radiation therapy worse. 40% of those patients who receive concurrent treatment are diagnosed with an acute dysphagia, so it's a significant number. Additionally, adding cisplatin to the regimen is noted to lead to an earlier onset of toxicities, including sore mouth, vomiting, and dysphagia. A number of chemotherapy drugs can alter taste, contribute to dry mouth, develop oral thrush, mucosal ulcerations, and causing dysphagia. Also, radiotherapy to the mediastinum causes changes to the esophageal mucosa, which can result in esophagitis. Mucositis and stomatitis are the most documented causes of dysphagia in patients receiving chemotherapy. Oral mucositis is probably the most common debilitating complication of cancer treatment, particularly chemotherapy and radiation. It can lead to several problems, including pain, nutritional problems as a result of inability to eat, and increased risk of infection due to open sores in the mucosa. It can interfere with daily activities of speaking, eating, and swallowing, having a overall negative impact on quality of life. Mucositis and stomatitis can cause erythema, swelling, bleeding, painful ulcerations of the mucosal lining of the mouth, which can result in difficulties maintaining adequate nutrition, can lead to dehydration and malnutrition, and again, impact overall quality of life. Here's some signs and symptoms of mucositis: red, shiny, swollen mouth and gums, blood in the mouth, sores in the mouth, sores and pain in the mouth and the throat, difficulty swallowing and talking, feelings of dryness, mild burning or pain when eating, soft whitish patches or pus in the mouth or on the tongue, and increased mucus or thicker saliva in the mouth. Taste changes can impact oral intake and nutrition. They can occur a few hours after completing a round of chemotherapy or days after. Often, patients will complain about bitter taste or metallic overtones, or that things are too sweet, or just an overall loss of taste. Next, we're going to talk about elements of the clinical evaluation of swallowing. We need to gather detailed case history, including medical history, including cancer diagnosis, cancer treatment history, whether it's current or has happened in the past, any surgeries that have occurred, is there a history of pneumonia or respiratory disease, any other prior neurologic problems. And we need to gather a complete history of the patient's swallowing complaints. What are the initial complaints? What's happening when the patient is eating or drinking? When is the onset of this difficulty? What does the person do when this problem occurs? How frequently does it occur? Does it occur at certain times of day? Does it occur during or after eating? Is there an avoidance of certain foods? Is there coughing or choking? Is there regurgitation? Any information that the patient can provide you regarding what's happening when they're eating or drinking is helpful to make a plan for this patient. You're going to look at, are they eating orally? Are they eating through a feeding tube? And overall, what are their reports about nutrition, or what do you observe about their presentation in nutrition? You also want to take note of their vocal quality, listen for vocal changes, any complaints of vocal changes from the patient, and gather that information. Patient-reported outcomes appear to improve both quality of life and outcomes in patients with advanced metastatic lung cancer. So this is a helpful tool to gather during the evaluation process and can be used in the therapy process. That gives you a really good overview of how the patient is feeling and their overview quality of life based on swallowing. It can help us to better understand the person's physical, mental, and emotional state of where they are and the implications of this cancer and the effects of treatment on patients. The swallow qual is a specific patient-reported outcome that relates to swallowing. It was developed to assess the severity of oropharyngeal dysphagia on quality of life. There are 11 quality of life concepts in this swallow qual outcome, including burden, eating duration, eating desire, symptom frequency, food selection, communication, fear, mental health, social, sleep, and fatigue. Each item is given a score indicating worst to best. The lowest scores are more indicative of a dysphagia as compared to the higher scores. So as you use this through treatment, you can see changes in their overall quality of life based on their answers, whether things are getting better or worse. It really is a great tool, gives you good feedback to help with your assessment and your treatment. Here's an example of a question from the swallow qual. Below are some general statements that people with swallowing problems might mention in the last month. How true have the following statements been for you? Here's the statement. Dealing with my swallowing problem is very difficult. And the other one is my swallowing problem is a major distraction in my life. So you can see here how they're going to choose whether it has significant impact, somewhat. If it's somewhat true, a little true, not true at all. This will give you a really good idea of where they are and how their swallowing difficulty is impacting their quality of life. You'll want to complete a thorough oral motor evaluation, looking at their oral and dental health, looking at facial velar symptoms, looking at overall lingual and labial strength and range of motion, jaw excursion, sensory perception, noticing if there's any dry mouth, xerostomia, mucositis, oral thrush, lymphedema, anything in the mouth or throat area that is remarkable. Next, you'll determine if oral trials are appropriate. Very often I might try liquids first, as those might go down a little bit easier. But as you go through your trials of liquids and foods, you'll be looking at how is the bolus formed, how is it transported, what's the timeliness of how the bolus is manipulated, is there oral residue, was there a lot of effort needed for manipulation of this bolus orally, is there a lot of movements, a lot of lingual movements, how is labial seal closure. You may also want to notice as the patient is feeding themselves, what size bolus do they accept? Are they taking very, very small nibbles? Are they taking a normal size bolus? Are they taking a quarter of a teaspoon at a time? Make note if they're grimacing when they're manipulating this bolus in their mouth. Are they complaining of pain? Are they indicating that they have a preference more towards a cold liquid or cold food versus room temperature? Are they reporting any changes in their taste as they're trialing these foods? You want to look at the pharyngeal swallow, hyolaryngeal excursion, the timeliness of the swallow. Are there multiple swallows? Is their patient reporting the food is getting held up in the throat or the esophagus? Are there coordination between bolus manipulation, respiration, and swallowing? Do you see them getting short of breath during these trials? Is there coughing or throat clearing or any vocal changes noted? Listen for any complaints of a globus sensation, any belching observed, any complaints of food getting held up in the mouth or the throat, any sensations of the bolus moving slowly through the esophagus. Based on your thorough case history, your patient complaints of swallowing, and whether you did PO trials or not, you will make a recommendation for whether you will continue to recommend a PO diet or recommend NPO with alternative means of nutrition. You may talk about safe swallowing strategies to them, which we'll talk about further, so that they can implement to be as safe as possible and optimize their nutrition and their intake. You may make a referral for an instrumental assessment, whether a modified variant swallow or fee study. You may also want an instrumental assessment as a baseline before the patient is starting treatment. You may need to refer to a dietitian who can discuss options for increasing caloric intake and maintaining adequate nutrition. And you may need to make an ENT referral if there's some vocal changes and you're suspecting the dysphagia is due to vocal changes. And finally, interventions for improving dysphagia. We may look at preventative treatment, therapeutic interventions, working to potentially avoid dysphagia-related malnutrition or aspiration pneumonia, minimizing complications and symptom burden, and hopefully improving overall quality of life. The speech therapist will most likely recommend dietary changes or modifications and swallowing strategies. This can include liquid consistency recommendations and food consistency. With the liquids, there may be a recommendation for cold liquids as these will go down easier. Maybe use of a straw or no straw, depending on how the patient is presenting, and perhaps teaspoon presentation with foods if needed, as compared to larger mouthfuls. With food consistencies, there may be a recommendation for more puree foods or soft foods that have less texture, less roughness to the foods, that will allow for an ease of swallow. Also, extra moisture, gravies and sauces may be recommended for the foods. Again, to give that, to allow for the swallow to go down a little bit better. There may be some difficulty accepting pills, so there could be recommendations to modify how the pill is accepted, whether it's crushed and whole, or put in a puree consistency, preferably something cold that might go down a little bit easier if there is still complaint of pain, or maybe just one pill at a time with the swallow, or one pill at a time with a puree versus a liquid. There's some variation that is patient specific there. Additional swallow strategies might be recommended, particularly controlling the bolus size. The smaller the bolus size, the easier it will go down through the pharynx and the esophagus, go down easier, and also with less pain if again, pain is a complaint. So perhaps just taking a smaller mouthful, a smaller bite, or a very measured control amount of half teaspoon, quarter teaspoon, 1 teaspoon at a time. Alternating food and liquids can also be beneficial, as the liquids can help move the food down through the pharynx and through the esophagus. Postures and maneuvers may be recommended. Perhaps pacing or coordination strategies, so that if the patient is getting shorter breath during meals or is observed with increased effort, during meals or during intake, um, slowing down the intake, but also coordinating with the respiration, the bolus manipulation, and the swallowing can help optimize the respiratory function during mealtime and make the meal or the intake overall more pleasant and less stressful for the patient. Often small, frequent meals is more helpful as it may take longer for the person to eat and drink using these strategies to eat small bolus size, alternating foods and liquids, and just due to the overall pain or complaints or difficulty swallowing. So having very small, frequent meals is helpful throughout the day, not feeling overwhelmed with a whole big meal in front of them that may just take too long to eat, and it may just be too much work and too much effort for the person. Education for these patients involves giving strategies for managing taste, appetite, and to handle their dysphagia. Some of the most obvious ones are obviously having a good oral hygiene, brushing frequently throughout the day, using a soft toothbrush, using a non-alcoholic mouthwash, perhaps as a prescription mouthwash that they have. Plastic utensils is often better than having silverware due to the metal taste. So the plastic works better. There's less metal taste in their mouth when they're eating. Sugar-free mints and sugar-free gums are always good. Chewing on ice to mask the bitter metallic taste. Chilling or freezing foods that are more acceptable than perhaps the warm or the hot food. Increasing fluid intake, going for foods that are non-spicy, bland, stay away from acidic foods, carbonation, extreme flavors, so salty, sour, and acidic. Prepare foods that look good and smell good so that there's some desire for this food. Red meats can often taste bitter, so perhaps going to poultry, fish, eggs, dairy products, soy products, it might be more desirable for the patient. There's also an option to rinse your mouth well before eating. One formula here is some warm water, salt, and baking soda that can be used, as long as it doesn't contain alcohol. And then minimize eating around the chemotherapy treatment session, also is helpful. It's also important to work with the medical team also to manage the pain in any other ways. There may be some medications that the doctor can prescribe that can help for the pain, that can reduce inflammation. There are some saline mouth rinses that can be helpful. There's prescription miracle mouthwash. All of these products can be helpful to reduce that pain, to make the eating and drinking a little bit more pleasant. Also, addressing the xerostomia through whether over-the-counter products or just suggestions for managing that dry mouth. There's quite a few suggestions for substitutes, artificial saliva and substitutes on this PowerPoint here. It's worth trying if you are just sharing this information just from experience. Certain patients like certain products more than others. So just provide that information out to these patients and they can see what works best for them. Additional suggestions include chewing sugar-free gum, again, taking sips of water, a cool mist humidifier can help, avoiding caffeine, and avoiding toothpaste and mouthwashes that contain any alcohol. I had mentioned earlier about a patient outcome tool of the Swallow Quell. This is helpful again in the treatment sessions just to really get a good idea of how the patient is doing and how their swallowing is impacting their quality of life and how you can help minimize the difficulty with swallowing and with just comfort to help them improve their quality of life. I thought this was an interesting quote to end off on. One of the very nicest things about life is the way we must regularly stop whatever it is we are doing and devote our attention to eating. With this population, eating is a job. It's setting up and planning of when, what, how you're going to eat. And now mealtime may not be enjoyable for them at this moment. Hopefully, with our help, we can keep them safe and guide this through this them. We can guide them through this process so they can enjoy their meal times once again in the future. Thank you for listening to this presentation. Have a good day.
Thank you all for your time in joining us this evening. Please note that to refer a patient to our program, you can email us at cancerrehab@northwell.edu or contact us at 833 480 0538. Have a great evening, all.